A hearty welcome to our esteemed guest, Dr. Chen, from the very famous Mayo Clinic in the USA. Dr. Chen is professor of ophthalmology and neurology at the Mayo Clinic in Rochester, Minnesota, USA. He did his medical school and a PhD from the University of Virginia Medical School. And he completed his ophthalmology residency and neuro-ophthalmology fellowship training at the University of Iowa. He serves as the Neuro-Ophthalmology Fellowship Director and has received numerous teaching awards. He co-chairs the Upper Midwest Neuro-Ophthalmology Group and is on multiple committees for the American Academy of Ophthalmology. I have been to the Mayo Clinic, and I can tell you that it is so true how it is the #1 best hospital in the entire United States. And Dr. Chen and I have worked on projects together. He's written book chapters. We've talked about patients together. And I tell you, he is just a gem of a human being, and one of the most brilliant ophthalmologists that I have met. So without further ado, we are so grateful and honored to have Dr. Chen with us to teach us chapters 9 through 15 from the AAO BCSC book.
Well, thank you so much for that kind introduction. And, it's really an honor to have a chance to chat with all of you. And I loved your visit here, and I've loved all our collaborations in the past. And it's just wonderful that you're organizing all of this. It really is special, really special. So really over the next hour and a half, we're going to go through, 7 chapters in the BCSC. So we're going to kind of fly through it. Really, the 2022 and 2021 versions are actually the same. In 2021, we had a large major revision. So the version you have is actually the same as the 2022. That was just a minor revision. I had a chance to be one of the editors of the book, and we spent hours and hours on this. It's something that we're proud of, and something that I think has a lot of good teaching points. So definitely a good resource. We're going to focus really on the first 3 chapters, and then the last 4 chapters will go by pretty quickly. But the first 3 have a lot of meat to them. Chapter 9 is supranuclear disorders of ocular motility. Chapter 8 was the infranuclear. So we're going to start supranuclear. And essentially what that means is anything above the ocular motor nuclei. So in the brainstem, we've got nucleus 3, 4, and 6 for eye movements. And if you have any lesion above that, that's considered supranuclear. And so that's your in your cortex, your prefrontal eye fields. In the brainstem, we've got, for horizontal movements, we've got the PPRF. For vertical movements, we have the RIMLF. And we've got the cerebellum that helps integrate things as well. And so anything above the ocular motor nuclei is considered supranuclear. And then infranuclear is essentially the ocular motor nuclei and downstream. So that includes the nuclei, the nerves, neuromuscular junction, and extraocular muscles. Those are all infranuclear, kind of below the nucleus. So I thought I would just start off with cases. Essentially, we're just going to have scattered cases throughout, because I think that's the best way to learn. This is a 52-year-old male who is admitted for left facial weakness and dysarthria. And ophthalmology was consulted because he said he just couldn't move his eyes. He does have a history of melanoma with metastases to the brain. And we have a video here. And essentially what you can see here is that with involuntary saccades, I'm trying to have him move his eyes. And he just really could not move his eyes around. We checked smooth pursuit, and he couldn't follow my fingers left or right. So in a patient like this, is there anything you'd want to do on the clinical bedside exam to try and evaluate maybe he's got a supranuclear gaze palsy? What can you do on exam? Again, I had him try and do smooth pursuit. He couldn't follow my fingers. I had him look up, look down. He couldn't move his eyes. Anything you'd want to do on exam? Any thoughts? Again, this patient's sitting there in the clinic or in the hospital. He just can't move his eyes around. Any bedside exam to determine maybe this is a supranuclear gaze palsy? Is there reflex we can take advantage of? Okay. So right now what I'm having them do is look at the camera and I'm moving his head. And then you can see when I'm moving his head, his motility is actually very, very good. And so this is essentially taking advantage of the vestibular ocular reflex. And it looks like Sangeeta said, Dahl's eye reflex, vestibular ocular reflex, perfect. That's how we're going to determine if this is supranuclear or not. And for him, he had complete ophthalmoplegia, but it was overcome with the vestibular ocular reflex or Dahl's eye. And so this is a clinical diagnosis of ocular motor apraxia. And so this is essentially a classic supranuclear gaze palsy. Essentially, anytime a patient has a gaze palsy, whether they can't look up with both eyes, left, right, or down, the first thing you want to do is check the vestibular ocular reflex to see if that's intact. And if it's intact, then it's a supranuclear gaze palsy as opposed to infranuclear. And for this patient, the reason why he had ocular motor apraxia is he previously had metastases to the frontal lobes on both sides. When he came to the hospital, he had hemorrhagic transformation here. And so you could see that he kind of damaged both frontal eye fields, leading to this supranuclear gaze palsy that was overcome with the vestibular ocular reflex. So again, that's how you're going to differentiate between supranuclear and infranuclear. This is a 65-year-old male with acute onset horizontal diplopia. I have another video here. And you can see when he's trying to look to the left, that right eye cannot adduct all the way. And then this motility was pretty good. Another thing I want you to take a look at is right here. He's got this abducting nystagmus in that left eye. So this is pretty classic for an internuclear ophthalmoplegia on the right-hand side. And that's why he can't adduct that eye. Essentially, this is an INO. It's a lesion of the medial longitudinal fasciculus on the right-hand side, causing an INO. And then is this supranuclear, infranuclear? It's a little bit of a trick question. This is actually an internuclear ophthalmoplegia. It's a connection between the sixth nerve nucleus and the third nerve nucleus. So that's an INO. So in terms of an INO, again, as we mentioned, this patient had a right INO. He had a lesion to his right MLF, the medial longitudinal fasciculus. And that MLF connects the sixth nerve nucleus to the third nerve medial rectus to kind of yoke the eyes together. So if you have a lesion, you get an ipsilateral adduction deficit. And then oftentimes you'll get contralateral abducting nystagmus because that eye, the left eye can abduct, the right eye can't adduct. And then so essentially they're trying to adduct that right eye. And then with Herring's law, that left eye just starts kind of beating to the contralateral side to the left. And essentially, if you have an INO, it's important because it's not going to be caused by microvascular palsies. These are lesions within the brainstem. So essentially, it's going to typically be, if they're old and acute, it's going to be a stroke. If they're young, it's going to be multiple sclerosis. And of course, you can have tumors, hemorrhage, all those kinds of things in the brainstem as well, but it's never benign. Again, you had your talk on infranuclear lesions last time, chapter 8, and you've got your isolated sixth nerve palsies. Those are often benign in elderly patients. It's just a microvascular palsy that gets better over time. If you see an INO, it's never going to be benign. It's going to be usually stroke if they're old, MS if you're young. And again, if you have an adduction deficit, you also want to think about mimickers like a myasthenia gravis, a third nerve palsy. But again, anytime you have an adduction deficit, you want to think INO and then start looking for the etiology. It's never going to be benign. So this is that same patient here where, again, has a very classic right INO that you can see, that adduction deficit there, the abducting nystagmus in the left eye. And then when he looks to the right, motility looks fairly full. But what I want you to look at here is what I'm going to do now is I'm going to have him actually saccade left and right. And I want you the speed of the adduction when he does this. However, first we're still checking smooth pursuit. We're seeing again the classic right INO. And then smooth pursuit to the left. Motility is fairly full. You could say, well, maybe there's a slight adduction deficit here, but it's hard to say. But again, now what we're going to do is we're going to look at saccades. And what you're going to notice is there's a very slow saccade actually in both eyes for adduction. So this patient actually has a clear right INO, but also has a left INO, just asymmetric. So it's a bilateral INO. So I guess the teaching point here is when you have a patient where you're suspecting MS or stroke, you not only want to check smooth pursuit, you want to check saccades. And sometimes the only thing that you notice from an INO is a slowed saccade. So these subtle INOs, again, are seen more easily with saccades. I just have them look at my thumb, finger, kind of back and forth, looking for that slowed saccade. We'll see it one more time here. You can see how that one's just a little delayed compared to this one in terms of adduction. Do you see that delay? And again, that's your INO, even on the left. All right. Here's another case. This is a 65-year-old man with acute onset horizontal diplopia. And these are the 9 cardinal gazes. And what you can see here is that in left gaze, he can't abduct the left eye, can't adduct the right eye, but everything else is fairly intact. So essentially, he's got a left horizontal gaze palsy. It's kind of what you would kind of call this. And again, anytime you've got a gaze palsy, the first thing you want to do is vestibular ocular reflex to see if you can overcome it, to see if it's supranuclear or infranuclear. So where does this localize? Again, this left horizontal gaze palsy. Any thoughts on where the lesion could be? Where is this in the brainstem? I'll give you the options of midbrain, pons, medulla. Is this horizontal gaze palsy localized to? And then the maneuver that we're going to help localize is the vestibular ocular reflex. And again, we talked about if it's intact, it's a supranuclear gaze palsy. If it's not, it's infranuclear. And ultimately, what we know is he can't move both eyes to the left. So this is a horizontal gaze palsy. So we know that the horizontal gaze centers are actually sitting in the pons where the 6th nerve nucleus is. So this is just a schematic of the brainstem here in the pons. And before, when you had a lesion to the MLF, that's your INO. But if you have a lesion to that 6th nerve nucleus, you don't just get a 6th nerve palsy, you actually get a horizontal gaze palsy. Because essentially, if you knock out that 6th nerve nucleus, you knock out, of course, the 6th nerve. That's what we expect. But you also knock out this connection to the 3rd nerve. And therefore, again, that right eye can't adduct, and that's how you get the horizontal gaze palsy. In terms of how the horizontal gaze patterns work, you've got the frontal eye field on the contralateral side that feeds into the PPRF, that feeds into the 6th nerve nucleus. And again, that's what drives horizontal gaze. And so for this patient, we tried doing a doll's head, and we weren't able to overcome his left horizontal gaze palsy. So he had a stroke to the abducens nucleus, not to the PPRF. And then there's that lesion here, showing that lesion to the 6th nerve nucleus. Again, small lesion, but was right there where the 6th nerve nucleus was, causing that horizontal gaze palsy. I just wanted to show this. There's a link in the BCSC book. It's actually an interactive thing in the BCSC where you've got your horizontal gaze movements. And this is something we designed with the last version. And essentially what you can say is, I'm going to lesion the 6th nerve nucleus. And when I have them look to the left, they can look to the left. But when I have them look to the right, they can't look to the right. So again, they can look to the left if you've got a right nerve nucleus lesion, but you can't look to the right. Or if you knock out the PPRF, which actually feeds into it, again, can't look left, can't look right, can look left, can't look right, but you can overcome it with doll's eye, because again, that's supranuclear, it's above the 6th nerve nucleus. And so again, you can do head turns or gazes, whereas if it's a 6th nerve nucleus lesion, you can't overcome it with doll's head. You can't overcome with the vestibular ocular reflex. And so you can actually play with this and do all separate lesions. You could do MLF lesions, you can do frontal eye field lesions, and kind of see what happens to the patient. So it's just a fun resource that's in the BCSC book that we created with some illustrators. And it was a lot of fun kind of putting this together. So that's there as a resource, and I just wanted to show that to you. All right, another elderly male with acute onset double vision. So this patient, very, very similar, has a left gaze palsy here, can't look to the left. But on top of that, the prior patient could look to the right, but this patient can't adduct the eye in that left eye. And so he's got a left gaze palsy and a left adduction deficit. Any thoughts on what this is clinically called? And it's a tough one, but it localizes very, very well. But essentially what we're seeing is a left gaze palsy and essentially a left INO. And so this is actually what we call essentially what it is instead of just hitting the sixth nerve nucleus, the lesion's large enough that it's also hitting the MLF. And so what we call this is a 1.5 syndrome. Essentially, the only motility that's intact, the only motility that is intact is abduction of that right eye. Everything else is paralyzed. You know, he can't adduct this eye, can't abduct this eye, can't adduct this eye, but he can abduct this eye. And again, we call this a 1.5 syndrome. And so essentially it's because he's knocked out the sixth nerve nucleus, but also knocked out this MLF coming to the ipsilateral side. So this is a 1.5 syndrome. It localizes the brainstem. Same etiologies you have to think about. Elderly, it's stroke. Young patients is MS. And then what's interesting is he also had facial weakness. So this is him trying to smile, and you can see this facial weakness on the left-hand side. And that actually localizes quite nicely. And it's actually called an 8.5 syndrome because you've got your 1.5 syndrome plus a seventh nerve palsy. So 1.5 plus 7 is 8.5. So again, we kind of jokingly call this an 8.5 syndrome when you've got your seventh nerve involved. And that happens because of the anatomy of the seventh nerve. The seventh nerve nucleus is here in the brainstem, in the pons, and it actually sends its nerve that wraps around the sixth nerve nucleus. So if you get a large enough lesion to affect the sixth nerve nucleus, you can often get ipsilateral facial weakness as well. So that's that 8.5 syndrome. That's what this patient had. They knocked out their sixth nerve nucleus, causing the horizontal gaze palsy. They knocked out their ipsilateral MLF, causing that INO, and they knocked out their seventh nerve. And again, all these pathways are all close to each other. This is a 55-year-old female with acute onset of difficulty moving her eyes, especially up. And so what you can see here is that she can't look up at all, but with vestibular ocular reflex, the motility is improved. You can see here, you can see some inferior sclera here, where here when she's trying to look up, she can't look up at all. She also has lid retraction, and she has some very striking findings that you can see on the video here. This is a patient I saw when I was at the University of Iowa. So this is Dr. Thurtell. So with these stripes, she's trying to look up now, and she can't look up to follow the stripes. What we do notice is that her eyes tend to kind of retract in a little bit. You see that kind of retracting in. This is called convergence retraction nystagmus. Another striking feature of this is if you shine light at her pupils, this is an infrared camera, pupils don't respond to light at all. Really no response. But when we have her look at a near target, the pupils come down really nicely. And this is called light near dissociation. So that's that classic light near dissociation that you get with this condition. Any thoughts from the residents of what this could be? So again, she's got vertical gaze palsies that are overcome with vestibular ocular reflex, lid retraction, light near dissociation, convergence retraction nystagmus. There's only one area in the brain this could be. Any thoughts? I see in the chat. Dorsal midbrain syndrome. Exactly. This is dorsal midbrain syndrome. So this is dorsal midbrain syndrome, or Paranaught syndrome is the other name for it. I actually like to use the term dorsal midbrain syndrome because it tells me that that's where the lesion's going to be. It's going to be a dorsal midbrain. And it also reminds me that that your vertical gaze centers are sitting in the dorsal midbrain. And if you've got dorsal midbrain syndrome, you could have one or all of these features: that vertical gaze palsy, often overcome with vestibular ocular reflex. People light near dissociation. They get lid retraction, so they'll often look surprised because their lids are pretty prominent. They get that convergence retraction nystagmus, especially when they try and look up or down. They often have a little bit of vertical double vision from a skew deviation. So this is your classic dorsal midbrain syndrome. It's again, if they're elderly, it's usually stroke. If they're young patients, it's typically MS, or there's another tumor that can actually happen and cause dorsal midbrain syndrome, which is a large pineal tumor. So your pineal gland is typically right here. And if you get a tumor in that area, it will actually grow downward and it can actually press on the dorsal midbrain. And so again, most common causes of dorsal midbrain syndrome are pineal tumors, stroke, and MS. Those are the things you're going to be looking for. Never benign, always something wrong with the brainstem. Again, I like it because it localizes very well. And two, if you remember that one of the key features of dorsal midbrain syndrome is a vertical gaze palsy, you'll remember that the vertical gaze centers are actually in the dorsal midbrain. So here's your vertical eye movements. And again, it's predominantly in the dorsal midbrain. Your RIMLF feeds into cranial nerve number 3, which is again in the midbrain. And that's really what drives your vertical gaze. Your RIMLF is equivalent to your PPRF. The PPRF is in the pons, which feeds into the sixth nerve nucleus and generates horizontal saccades. The RIMLF is in the dorsal midbrain, feeds into the third nerve nucleus and the fourth nerve nucleus, and triggers vertical saccades. So that's your vertical eye movements. And remember, if you remember dorsal midbrain syndrome and you've got vertical gaze palsy, you always remember that the vertical eye centers are in the dorsal midbrain. So that's really it for chapter 9. We're going to switch over to chapter 10 now, and this is nystagmus and spontaneous eye movement disorders. So I just thought we'd start off with a video here. So in down gaze, not too much, but you could see in primary that the eye was bouncing. And what you'll see here is when she looks to the sides, the eyes will bounce even more. You can see this vertical bouncing. And when she looks up, there's really not much movement. And then when she again looks to the sides, you're going to see the pretty prominent vertical movement right here. So this is pretty classic for a certain kind of nystagmus. You can see it in more detail here. So which way do you see the fast phase moving? Is it moving up or down? And what is this nystagmus? Well, because the eyes were bouncing down, that's the fast phase. We would call this a downbeat nystagmus. The direction of the nystagmus is based on the fast phase. So nystagmus is a rhythmic to and fro eye movements. In terms of jerk nystagmus, there's 2 phases. There's the slow phase away from the visual target, and then the corrective fast phase back to the target. And we actually call the nystagmus based on the fast phase, even though the pathology is drifting the other direction slowly. We call the fast phase, corrective phase, the direction of the nystagmus. So in this patient, the pathology is her eyes just keep on to drift up, and then she corrects it by dropping her eyes back down. Again, this is a downbeat nystagmus, but the pathology is actually the eyes want to drifting up. So that's jerk nystagmus. And then there's pendular nystagmus, where there's just slow phase movements only. And then there's saccadic intrusion, which are fast phase movements only. There's no slow phase, so it's not a true nystagmus. And we'll step through some examples of these. But again, nystagmus is a to and fro eye movement. And then when you have a patient with nystagmus, you want to see, is it dissociated, disconjugate? So sometimes if you can use dissociated, means it's an amplitude that differs in each eye. And disconjugate means that the direction of the oscillations are different. So that's helpful to know. And then you want to know, does the patient have oscillopsia, which is a symptom of nystagmus? So essentially, if your eyes are bouncing and it's acquired nystagmus, they're going to have oscillopsia. It's going to be as if you're looking at an old camera recording that has no visual stabilization. You can see how nauseating that is to see that movie with all that bouncing up and down. That's what patients have when they have acquired nystagmus. Whereas if you've got congenital nystagmus, you've had nystagmus your entire life, your eyes are bouncing all over the place, but the patient doesn't actually even notice the oscillopsia. So anytime you see bouncing eyes, you want to ask, do they have oscillopsia? Do they have bouncing of their movement that they actually notice? So on exam, even if you don't know the nystagmus, if you can actually tell me these features, we can actually figure it out together. I want to know if it's monocular or binocular. I want to know it's conjugate or disconjugate. The pattern, is it horizontal, vertical, torsional, mixed? Is it induced by a particular eye position? Is there a slow phase only, fast phase? Is there a null point? If you look at any patient with bouncing eyes and you can fill this all out, even if you don't know the kind of nystagmus, we can figure it out together. So again, downbeat nystagmus is one of the most common nystagmus that we see. It's a vertical jerk nystagmus with a fast phase downward. And it's often increased in lateral gazes and decreased in up gaze. Pretty classic for downbeat. And in terms of etiologies, it's often due to involvement of the vestibular system. And so the classic lesions are the cervical medullary junction or cerebellar lesions. And you can have some toxic or metabolic causes that are less localizing, like lithium magnesium deficiency, Wernicke's encephalopathy. These are all things that can cause almost any kind of nystagmus, including downbeat nystagmus. But a common thing that we see it is in cerebellar degeneration in patients with familial ataxia, where they just develop a late stage ataxia in their 60s or 70s. Sometimes they'll have a downbeat nystagmus with it. Downbeat nystagmus, we're just going to keep coming back to this, kind of localizes classically to the cervical medullary junction. So if they've got a Chiari, that's a common cause, or cerebellar dysfunction. That's their classic downbeat nystagmus. And as we step through the nystagmus, we'll talk about where each one localizes in the brain. So that's downbeat, again, one of the most common ones. Even general ophthalmologists see downbeat nystagmus from time to time. This is a less common one, but very, very striking, very, very interesting. So I'm just going to play the video here. And first off, is it conjugate or disconjugate, would you say? Again, are the eyes going in the same direction or opposite direction? And then the other question we want to have, what's the direction? Is it horizontal, vertical?
You can unmute or you can even post on the chat, whatever you feel comfortable with, guys.
And then we want to know, is it fast phase or slow phase only? You know, is this a jerk nystagmus or a pennular nystagmus? And we've got some chats here. We've got disconjugate, vertical, perfect. Any thoughts on what this nystagmus is? I agree, disconjugate, vertical, and would you call this pendular or jerk? Show one more time here. Do you see any fast movements or is it just kind of slow? Perfect. And I saw the answer too. I saw seesaw. So it's disconjugate, vertical, pennular, and this is seesaw. This is seesaw nystagmus. Thank you so much for that. So again, we stepped through all this. You all with the chat correctly identified that it's vertical, it's slow phase only, it's binocular, it's disconjugate. And this was seesaw pendular nystagmus. So now brownie points, this is super rare, but where does this localize? Again, the reason why I brought this up is not because it's the most common nystagmus, but it actually localizes in the brain very, very well. There's only one spot in the brain this could be. This is a much, much harder question. I can tell you that these patients sometimes have bitemporal hemianopias. So where would that localize to? Chiasm. Perfect. Yeah, so these patients have bitemporal hemianopia. This patient had a bitemporal hemianopia, as you can see. And it localizes kind of in this precellular area here, the diencephalon right here. And that's where seesaw nystagmus localizes to. So it could be cranopharyngioma. This patient actually ended up having a traumatic chiasmal injury when they're young. That's how this patient had seesaw nystagmus. But you're right, it could be cranopharyngioma, it could be meningioma, it could be pituitary adenoma. It's interesting, we see these lesions all the time affecting the chiasm, and we rarely see seesaw. So I'm not sure why seesaw happens in some patients and it doesn't happen in other patients. But if you see seesaw nystagmus, there's only one place it can be, and that's going to be in that cellar region here. So that's where seesaw localizes. So again, rare, but if you see it, you know exactly where it's going to be. So very testable on exams as well. So this patient has right-sided incornation and reports her eyes are bouncing. You can see when she looks to the left, not too much, but when she looks to your right, you can see a lot more bouncing of her eyes to the right. And she's got incornation on that side too. Looking to the left, not too much. But when she looks to the right, again, some more bouncing. Where the fast phase seems to be going out and the slow phase is coming in when she looks to the right. So let's describe this nystagmus. I'd say it's binocular, I would call it conjugate, it's horizontal. It's not continuous. This is induced by a particular eye position. It's kind of in right gaze here. And then is it, you know, fast phase, slow phase? I think there's a fast and a slow, so it's jerk nystagmus. So this is kind of the description of this. And it only happens when she's looking to the right. Any thoughts on this nystagmus? Horizontal jerk nystagmus with the left null point. I like that. So this is actually induced by gaze. And so what this is gaze-evoked nystagmus. This gaze-evoked nystagmus that's mostly in right gaze because she had this right CPA epidermoid tumor that was resected, and you could see this damage to the cerebellum and the cerebellar peduncles in this area, and that's causing the gaze of nystagmus. So what a gaze of nystagmus is an inability to maintain fixation in a centric gaze. So again, we call it gaze of nystagmus because again, the fast phase is when they're looking to that gaze, but the pathology is actually the drifting back to the center. And the brain says, no, 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 I don't want to be in the center. I want to be looking to the right. So again, we call it gaze of nystagmus, but the pathology is the eyes trying to drift back to the center. And it's due to dysfunction of the neuronal integrators or dysfunction in the cerebellum. In terms of the horizontal neurointegrators, there's the nucleus prepositus hypoglossy, and the vertical neurointegrators is the interstitial nucleus of Cajal within the MLF. But usually when you see gaze of nystagmus, it's usually more in the cerebellum. In terms of differentiating this from physiologic end gaze, if we look far enough, we all have a tiny little bit of physiologic end gaze. But for these patients, they've got more profound nystagmus. And what I usually do is I have them kind of look about 75% of the way. If they look 75% of the way and they have nystagmus, then that's gaze of nystagmus. If I only see the nystagmus when they're way out, 99% of the way they can move, that's just physiologic end gaze nystagmus. And that's important because physiologic end gaze nystagmus is benign. Gaze of nystagmus is always pathologic. They can sometimes have rebound nystagmus as well. And so again, usually gaze of nystagmus classically localizes to the cerebellum, but you can also have these neurointegrators in the brainstem as well. This one for vertical, this one for horizontal gaze of nystagmus. Another thing that's important to note is that if you actually, I'm not advocating this, but if patients or people drink lots of alcohol, they actually will impair their cerebellum temporarily, and they will have gaze of nystagmus. So when police cars pull people over suspected of drunk driving, one of the things they do is they have you walk the line because they're trying to check your balance. Again, they're checking your cerebellum, and then they have you look at their finger as they look left to the right. And what they're looking for is gaze of nystagmus. Of course, the police officer doesn't know they're checking for gaze of nystagmus and they're looking for cerebellar function, but that's what they're essentially doing. If you have too much alcohol, your cerebellum gets impaired, you can't walk a straight line, and your eyes are not coordinated, and you have gaze of nystagmus. So again, that's a way to at least remember it. If you've got too much alcohol toxicity, you're going to have problems with your cerebellum. You're going to have gaze of nystagmus. Certainly not advocating that, but it's something, a way to remember. Another nystagmus you can have is upbeat nystagmus. It doesn't localize all that well. It can be medullary cerebellum. And essentially with upbeat nystagmus, the problem is your eyes are bouncing up and they're drifting back down, but the fast phase is in the upward direction. And so they're usually caused by brainstem or cerebellar lesions, MS, tumors, stroke. And I've seen it actually a few times with Wernicke's encephalopathy as well. Again, Wernicke's is something that can cause any kind of nystagmus. And so again, mostly in the medulla, maybe cerebellum, doesn't localize perfectly. And then we've got pennular nystagmus. So with pennular, you've got slow phase in both directions without a corrective quick phase. Also doesn't localize great, but it's often caused by multiple sclerosis. And oftentimes the speed is faster in the eye with greater vision loss after optic neuritis. It's due to impaired abnormal input from the neurointegrators. And we can try to treat all these nystagmuses with gabapentin, memantine, all these things they try to calm down nerves. That's what we try to do. So that's pennular nystagmus. I thought this was a very interesting one. This is a 54-year-old male referred for abnormal eye movements. He's got a history of a stroke 1 year prior affecting the cerebellum and right medulla. It caused cross-sensory loss, dysarthria, dysphagia, ataxia, vertical diplopia. That all got better. But any thoughts on what this is called, where you have a stroke causing all of these symptoms from a neurologic standpoint? This is called lateral medullary syndrome. But he actually improved from that. But then months later, he developed these abnormal eye movements. And so here's that stroke in the cerebellum, but also a stroke in the lateral medulla right here. And so here's eye movements. And what I would say is he's got this kind of kind of this torsional pendular nystagmus. I'm not seeing a fast phase. I'm just seeing more of this kind of vertical torsional nystagmus, which is more prominent in certain gazes directions like left and right. But essentially, it's this pendular vertical torsional nystagmus that again occurred 3 to 6 months after he had recovered from a stroke involving the medulla. I would say that there's no fast phase. I think it's just slow phase, and it's mostly vertical and torsional. So I'd call this a pendular nystagmus that's torsional and vertical that occurred 3 to 6 months after the stroke. That's the key. So he's got this vertical, torsional, pendular nystagmus that occurred after the stroke, not the time of the stroke, but 6 months later. So there's actually one more interesting thing you can do on exam to figure out. Again, this is what he's got, pendular and torsional nystagmus. One more thing you can do on exam, which is really interesting. What I'm doing right now is I'm looking at his palate. And what you can see is that palate is bouncing at the same frequency as his eyes. So any thoughts on what this odd entity could be? What's this called? What's going on? In a vertical torsional pendular nystagmus, and his palate's bouncing at the same rate. It occurred 6 months after his stroke. He had recovered perfectly fine, and then 6 months later, this comes on. Any thoughts? Are we worried about a new stroke? Are we worried about a tumor? Or is this something that can happen after a stroke? So wonderful, oculopalatal clonus. So this is oculopalatal tremor. So, or oculopalatal nystagmus, exactly as someone mentioned in the chat. So what this is you get this vertical torsional pendular nystagmus and palatal oscillations. And what brings about this is this lesion to Guillain-Barré's triangle, which is essentially a lesion anywhere in this pathway from the cerebellum to the red nucleus and the medulla. So if you have a lesion anywhere in this pathway, weeks to months after lesion, you can get hypertrophy of the inferior olive, and then your muscles start oscillating. So it's a very, very fascinating thing that can occur. And again, this is an example of what you see here. They had a stroke here, and then 6 months later, you can see this T2 and hypertrophy of the inferior olive. So that's what you're looking for on the MRI. And so that's essentially oculopalatal tremor. Essentially, you'll see it in the medulla, but it's any lesion from the cerebellum to the medulla to the brainstem, this Mallory's triangle, you can get oculopalatal tremor after the fact. And again, it's important to be able to recognize because oftentimes patients develop this later and they think that's a new stroke, or let's say a tumor resection was what initially caused the damage to Mallory's triangle, and then 6 months later they develop nystagmus. They're worried that the tumor is coming back, but it's actually not anything to do with recurrent disease. It's just this maladaptation pathway that develops causing this oculopalatal tremor. So oculopalatal tremor, again, if you see this vertical torsional pendular nystagmus, you want to open their mouth and look at their palate. I actually love making this diagnosis. The medical students are always just in awe because I walk in the room and I see this nystagmus and I say, open your mouth. And boom, there's your diagnosis. And it almost feels like you're like on House. Remember that show House where that doctor could make some crazy diagnoses? I kind of feel that way with this one too. So oculopalatal tremor. This one's very interesting. It's pretty rare, but it's important to recognize. So what you're seeing here is left jerk nystagmus. The fast phase is in the left direction. Slow phase is to the right. And then if you wait long enough, it actually stops. And now it starts jerking to the right. So now the fast phase is to the right after about a minute. And now it's clearly jerking nystagmus to the right. And it does this every minute or so. It kind of stops and it switches over to the left. And then it stops, switches over to the right. So what kind of nystagmus is this? Pan. Exactly. This is pan. This is periodic alternating nystagmus. And this is a classic one because this is the one where the resident comes in and then they go, Dr. Chen, we got a patient, they've got left beating nystagmus, and I walk in and I see right beating nystagmus, then our job is to just sit there and wait for 2 minutes and see if it reverses. So this is periodic alternating nystagmus or PAN. And then again, this horizontal nystagmus changes every 2 to 4 minutes. It's purely horizontal. It's due to dysfunction of the cerebellar nodulus or uvula, so it localized very well. And the other reason why you need to know this one is that most nystagmuses don't have very good response to treatments, but for periodic alternating nystagmus, it responds very well to baclofen. So it's one that actually responds. So there's your periodic alternating nystagmus. Again, localizes very well to the nodulus and the uvula of the cerebellum. Treatment is baclofen. There's peripheral vestibular nystagmus. We actually don't see these patients as much in the opto clinic. These are the ones that typically go to the ER because they're vomiting and have horrendously bad vertigo. And it's usually from a viral vestibular neuritis. There's benign paroxysmal positional vertigo, BPPV. There's Meniere's disease. These are all things that are really seen by the ER docs or ENT. We don't typically see very much peripheral vestibular nystagmus in the eye clinic. Then there's saccadic intrusions. So saccadic intrusions means there's fast phase only. There's no slow phase. So it's not a true nystagmus. And examples of saccadic intrusions are square wave jerks, macrosaccadic intrusions, and opsoclonus ocular flutter. And here are just some examples. So square wave jerk is these tiny little small movements around fixation, and they actually can be completely benign, especially in elderly patients. So again, I'm sure some people on this Zoom actually have some square wave jerks. If you have a lot of them, it can be part of a neurodegenerative condition like Parkinson's disease. But again, normal people have square wave jerks. But yeah, if you've got prominent ones, it could be Parkinson's and others, but very, very common in elderly patients. Then there's macrosaccadic oscillations, which you're gonna notice here are the movements are much larger than what you saw with square wave jerks. And this is always pathologic. This is indicative of a lesion to the cerebellum. So if you have macrosaccadic oscillations, you're thinking a lesion to the cerebellum, and you've got to figure out why that is. So again, these are macrosaccadic. They're much larger movements than square wave jerks. And so again, with square wave jerks, much smaller movements, the macrosaccadic oscillations are much larger. This is a patient with some hypermetric saccades. So every time I have her look, you can see she overshoots it. Again, because she's got something wrong with her cerebellum, it just shows that and she had a little bit of upbeat nystagmus and some gasovic nystagmus as well. But I just want to show the hypermetric saccades. When I'm trying to have her look at my finger, you can see it's kind of choppy, smooth pursuit. Again, all indicative of cerebellar disease. So this patient had a history of a cerebellar medulloblastoma that was resected. These eye movements you probably won't forget. Any thoughts on what eye movement this could be? You can see that there's no slow phase, so it's not a nystagmus, it's not regular. It's these fast saccades kind of moving in every direction. Any thoughts on what this eye movement is? What we'd be looking for? So essentially fast eye movements in every single direction. Thoughts? So this is opsoclonus. The other name for it is saccadomania, because again, the saccades are just going all over the place. So again, opsoclonus, and we're gonna be looking for perineoplastic syndromes. So they might have some tumor, cancer somewhere that's creating antibodies that's causing this. It could be an encephalitis. We've seen it in metabolic toxic states, multiple sclerosis, or idiopathic. So opsoclonus and ocular flutter are essentially back-to-back saccades without an intersaccadic interval. There's no slow fade, so it's not nystagmus. It's really this fast saccades there. If it's purely horizontal, it's ocular flutter. If it's multidirectional, it's opsoclonus. And it's thought to be due to malfunction of the omnipause neurons. So you just have these saccades that you can't control. So essentially, these are the wave directions of these saccadic intrusions. And again, if they're a child, you want to look for neuroblastoma. In adults, you want to look for small cell lung cancer, breast cancer, ovarian cancer. And this is the final nystagmus case we're going to have before we move on. This is actually one of our residents. Any thoughts on what this could be? So she can only do it for about 10 seconds, and she has some eyelid fluttering while she does it. And what I can tell you is about 8% of normal individuals can do this. So what is this? What is she doing? Any thoughts on what this eye movement is in the chat? Voluntary flutter. Yeah, this is voluntary nystagmus. So it's very fascinating. About 8% of the normal population can do voluntary nystagmus. Can't be sustained. I can't do it myself, but it looks like there's 93 people on the call. So I'm sure at least one person on this call can actually do voluntary nystagmus, and it's pretty impressive. But you can always tell because there's convergence effort, there's eyelid fluttering, there's facial grimacing, can't be sustained. That's how you can tell this apart from true pathologic ocular flutter. So again, final slide on nystagmus in terms of localization. Voluntary is that's in your frontal cortex. Seesaw, that's in your kind of paracellular region, which has the bitemporal hemianopia. Convergence retracting nystagmus, we heard in the last chapter from dorsal midbrain syndrome. Gaze evoked is going to typically be in your cerebellum. Oculopalatal tremor, OPT, is that lesion in Mallory's triangle anywhere between the cerebellum, the medulla, and the red nucleus in the midbrain, and that doesn't happen right away. It happens, 3 to 12 months later. Periodic alternating nystagmus, that's in the cerebellum and treated with baclofen. Upbeat can be multiple places, but often medulla, cerebellum, and downbeat is classically your cervical medullary junction or cerebellum. So that's essentially nystagmus in a nutshell. And then we'll move on to pupillary abnormalities. And we'll have to go a little bit quicker now so that we can get through the rest. So why do we check pupils? We're looking for relative afferent pupillary defect, because if we see one, it indicates optic nerve damage or retinal damage. And we're looking for anisocoria, which is unequal size, because those sometimes can be neurologically dangerous. So that's why we check pupils. In terms of the visual pupillary pathway, it really starts off with the optic nerve, which then synapses in the pretectal nucleus. The pupillary fibers go to the Edinger Westphal nucleus in the third nerve nuclei, then follow along the third nerve, synapse here in the ciliary ganglion, and then the short ciliary nerve goes to the iris. So that's your pupillary light reflex. And again, if you have an RIPD, it signifies asymmetric damage to the retina or optic nerve. And so based on these, this patient is 20/80 with a central scotoma. This patient has inferior defects in both eyes. This one's 20/20 with a large inferior defect. Which patient actually has the largest RAPD? What do you expect? I would say a lot of people pick this one because the visual acuity is down, and they think the visual acuity down, that's proportional to an RAPD. But in reality, your relative afferent pupillary defect is proportional to visual field loss, not visual acuity loss. So this patient would actually have the largest RAPD. Yeah, again, most people would pick the 20/80, but really the answer is this one because there's more field loss. So that's the answer. Because again, what's surprising to a lot of people is, again, it's proportional to the visual field loss, not visual acuity loss. It's important because it's not going to be caused by corneal lens opacity, amblyopia, or vitreous hemorrhage. If it's present, there has to be something wrong with the retina or optic nerve in one eye. And so this is a visual field, a gold mine, and you can actually quantify what you expect the amount of RAPD would be depending on how much visual field loss is missing. If you're missing the entire macula, you'd expect about a 0.6 to 0.9 log APD. If you miss the entire bottom of your visual field, you're going to end up having 0.3, so that's 0.6 plus 0.6, you end up with about a 1.2 log APD. And if you're missing everything, it's like a 2.4 log APD. So that's kind of an estimation in terms of what you expect in terms of degree. So actually, this patient is the one that had the largest APD because they have about a 1.2 log, whereas this one's missing the macula, this would be about 0.6. So this patient down here, even though they're 20/20, would have the larger APD. In terms of these patients, retina detachment, glaucoma, ischemic optic macular degeneration, Some patients you'd expect an APD, some patients you wouldn't. And actually the answer would be, if you've got a retinal detachment, that actually causes an APD. When the retina is peeling off, people think of APD as optic nerve related, but really retinal detachments, retinal damage will cause an APD as well if you have enough visual field loss. Glaucoma, it's pretty rare because usually glaucoma is pretty symmetric. Ischemic optic neuropathy almost always causes visual field loss, so you usually have RIPDs. And macular degeneration, even though your visual acuity is way down, you don't get that APD because it tends to just involve the macula. And again, so that really emphasizes that this RIPD is proportional to visual field loss, not visual acuity. It's super helpful because it's purely objective. It's incredibly helpful for patients with functional vision loss, non-organic vision loss. And in terms of how to quantify it, I like to use filters where you actually put the filter in front of the good eye to balance it out. And then you can actually approximate the RIPD by this little trick here, where if you look at the mean deviation, this is a minus 13. So you'd expect the APD to be about 1.3 log. And then this patient, you'd expect no RIPD because now they're symmetric. And this patient, where they've got worse vision in the left eye, you'd actually kind of subtract it to minus 22, minus 16. You'd expect about a 0.6 log in the left eye. So it's really about the difference in the amount of visual field loss is how much of APD you'd expect. And here are just some examples of checking for an APD. Yeah, I'm sorry. So it's not playing, but essentially how it works is you just swing the flashlight between the two eyes, 2 seconds per eye. And then what you're looking for is that escape of the pupil when you swing it to the eye with the APD. But for some reason, the videos aren't playing. So that's essentially why we look for APDs. Again, you're going to be using the swing flashlight test, 2 seconds per eye, going back and forth. And you're looking for one of the pupils to kind of enlarge when you swing it over. And that's indicative of an APD. It's proportional to visual field loss, not visual acuity. Then there's anisocoria, that's unequal sized pupils. So there's, if a difference is larger in dark, that could be physiologic anisocoria. About 20% of normal people have some physiologic anisocoria, but usually it's less than a millimeter. And the one that's dangerous is the Horner syndrome, which is larger in the dark. And then there's anisocoria larger in the light. That's your 80s tonic pupil, your third nerve palsy, or iris damage or pharmacologic mydriasis. So that's when you see anisocoria, you want to check, is the difference larger in dark or light to kind of help you with your differential diagnosis. Anytime you have a patient with anisocoria pupils, you really never want to look at pupils alone. You want to look for ptosis, you want to check motility, because the dangerous things with anisocoria are going to be accompanied by either ptosis or motility deficits, or both. If it's just isolated anisocoria, it's usually not dangerous. So you always want to check all three of these together. If you have a patient with a droopy lid, check the pupils, check the motility. If you have a patient with double vision, check the lids, check the pupils. Same thing with the pupils, check the ptosis, the lids, and the motility. I want to ask about prior surgery or damage. This is a patient who had prior damage to the right eye from a softball injury. And so they've got a lot of anisocoria, but it's actually just from trauma. You can see this iridodialysis. I wish I could play the video, but it's not playing right now. But that's, of course, something you want to look for. So this is a 57-year-old with anisocoria here that seems to be maybe a little more prominent in the dark. You can see in the dark compared to light. What are we worried about here? And are there any eye drop tests we can do to kind of help confirm our suspicion for this patient? This is a really important one. So pilocarpine test is one thing. That's we're looking for an 80s pupil. Tensilon, we're looking for myasthenia. They do have a little bit of ptosis, but there's anisocoria. So if there's anisocoria, that means it can't be myasthenia. So there's something else. We've got ptosis and a small pupil on that side that's dangerous and has to be really high on your differential. So cocaine. So that's one drop test we can do. Cocaine. So what are we looking for here? What are we worried about? So cocaine is one of the answers. The other answer is apriclonidine in terms of an eye drop test. But what are we looking for? Any thoughts? So small pupil on that side, slightly droopy lid on that side. We're going to do cocaine, Horner's. Wonderful. That's what we're looking for. We're looking for that Horner syndrome. And so essentially what we did is an apriclonidine test. And what you can see here is that the pupil got bigger and the lid came up. And this confirms our diagnosis of a Horner syndrome. And that's important because there's some dangerous etiologies that can cause Horner syndrome. And another test you can do is cocaine. That works as well. So this is a classic response to aproclonidine to confirm our Horner syndrome. And this patient actually had a carotid dissection. You can see this, what we call a crescent sign here in the internal carotid on the left. And on the MR angiogram, it's actually pretty hard to see, but there's a little bit of narrowing there. I actually find it easier to see on the MRI T1. This is a Horner syndrome. So this patient was started on aspirin. The pain went away, had mild improvement in the Horner syndrome, and fortunately had no other neurologic symptoms. And that's important because a Horner syndrome from a carotid dissection can actually cause a stroke in up to 25% of patients. So you got to make the diagnosis and start thinning out the blood. So Horner syndrome is damage to the oculosympathetic pathway, and it causes ipsilateral ptosis, meiosis, and anhidrosis. The anisocoria is classically larger in the dark. And then here's just the pathway of the sympathetic chain. It starts in the hypothalamus, comes all the way down the spinal cord, wraps around the lung, and it comes back up, jumps on the internal carotid. So carotid dissections can damage the sympathetic chain here. Jumps on the in the cavernous sinus on the abducens nerve just for a little bit, and then ultimately comes to the lung ciliary nerve, to the iris, and also innervates the mular muscle. So you end up with a little bit of ptosis. So that's your sympathetic pathway. Very, very interesting, complicated, long pathway that can get damaged by a number of different things. So this is a patient who has a Horner syndrome on the left. We gave aproclonidine, and you could see that the pupil got larger, the ptosis came up. In terms of the etiology, the hint is the oxygen. You can see he's got oxygen. This patient ended up having a lung tumor, a Pancoast tumor. So again, it can be a lesion anywhere from the brain all the way down around the lung, back up the neck again. Pete's Horner syndrome is important. We want to know, is it present at birth or is it acquired? Because there's dangerous things that can occur. There's congenital and traumatic at birth. Those aren't dangerous. But if it's acquired, and there's no Horner syndrome, but there is one 6 months later, you're worried about dangerous things like neuroblastoma. So in terms of congenital Horner syndrome, they often have some findings in addition to the anisocoria and ptosis, because the sympathetic involvement is involved in hair and iris color. So the hair is often straighter, the iris often lighter on the affected side. That will make you think that this is more of a congenital Horner syndrome that happened in utero while the patient was developing. Drop testing in a peds patient. This is important. Usually I use aproclonidine, but in pediatric patients, aproclonidine is contraindicated because it can cause CNS depression. It's really, really important. If you actually see a 6-month-old and you're thinking, gosh, I think there's a Horner syndrome, I'm going to confirm with aproclonidine in your clinic, you could put that patient in respiratory arrest right there in your clinic. So this is super important to recognize. If you're going to use eye drop testing, you're going to use cocaine if you want to confirm it. All right, everyone should get this one. This one's super important. So they have headaches, nausea and vomiting, dilated left pupil. You can see this dilated left pupil here. And she can't look up, can't look in, can't look down. She can look to the left. What is the diagnosis? I want everyone to have this diagnosis. Third nerve palsy. Perfect. And what does this patient need? Let's say you see this patient on a Friday afternoon at 5 o'clock, last patient of the day. What are you going to do with that patient? I love it. MRA. All right. So essentially what we're looking for is an aneurysm. And so we need some kind of angiogram, whether it's CT angiogram, MR angiogram. We're looking for that aneurysm. There's no A in MRI. There's no A in CT head. You need that CTA or MRA. And here you can see this. There's an aneurysm right here, which was coiled, and essentially saved this patient's life. So again, a third nerve palsy is a PCOM aneurysm until proven otherwise, especially if there's pupil involvement. And the reason why you can get third nerve palsies from posterior communicating artery aneurysms is the anatomy. So in the subarachnoid space, the third nerve leaves the midbrain before it goes in the cavernous sinus, and it runs parallel to the posterior communicating artery. So if you have an aneurysm, which is an outpouching of the artery that's about to rupture, some of the first symptoms could be an isolated third nerve palsy, usually painful. Although aneurysms only account for 6% of third nerve palsies, they really can't be missed because if they rupture, there's a 50% mortality rate. So really, third nerve palsies are aneurysms until proven otherwise. Before we used to have the rules of the pupil, where the pupil had to be involved, and then we're thinking aneurysm. Just throw the rules of the pupil out. If you see a third nerve palsy, it's imaging, whether there's people involved or not. So it's either CT, CTA, or MRI, MRA. And that A needs to be there. You're looking for an aneurysm. There's no A in MRI. There's no A in CT, but there could be an aneurysm. All right. So we're just going to end in terms of pupils on anisotropy in light. That's larger in light. So that's going to be our pharmacologic dilation, iris sphincter damage, AD tonic pupil, cranial nerve 3 palsies. The good part is an isolated dilated pupil is almost always benign. Obviously, you get a dilated pupil worried about that third nerve palsy. But a third nerve palsy is going to typically have ptosis. They're typically going to have motility deficits. It's so if you get an isolated dilated pupil, that's almost never going to be dangerous, but you have to be darn sure that there's no tiny little third nerve palsy hiding in there. So probably the most common cause of dilated pupil is an AD's pupil, where they have impaired parasympathetic innervation. And oftentimes you classically get this light nerve dissociation where we shine light in the pupil, it doesn't respond, but then to near it constricts better. So that's light nerve dissociation. And then you can do a dilute pilocarpine test to test for it. This is a patient with a right 80s, and you put dilute pilocarpine, diluted 1 to 10, and then to a normal pupil, it doesn't do anything, but to a patient with an 80s pupil, which develops this cholinergic denervation, you'll get constriction to kind of help confirm it's an 80s pupil. But really, the most important thing is if you have a patient with a dilated pupil, make sure there's no ptosis, make sure there's no motility deficits. You're ruling out a third nerve palsy because all the other causes of a dilated pupil, they're not dangerous, whether it's 80s, pharmacologic, they're just not dangerous. And then you've got light nerve dissociation. We saw that classic case of light nerve dissociation with a patient with dorsal midbrain syndrome. And then here's some other causes of dorsal midbrain syndrome, including syphilis is another one, and 80s pupil. What we need to know as ophthalmologists to not put our patients at risk for either permanent vision loss or life. So in terms of eyelid or facial abnormalities, I think the most common thing we see is Bell's palsy. It's super, super common. It's the most common cause of unilateral facial paralysis. And really the big thing is exposure keratopathy. Majority recover over 3 to 6 months. Studies have shown if you do corticosteroids and antivirals within 3 days of onset, it can quicken recovery. And really, just as ophthalmologists, we have to make sure they don't develop exposure keratopathy and a breakdown of the cornea. What's obviously very dangerous is you have both V1 and seventh nerve palsy. So if they can't feel and they can't close their eyes, that's very dangerous. And then these are just some videos of various other eyelid abnormalities you can see. This is benign essential blepharospasm. Essentially, these patients, you can see this kind of, they just can't keep the eyelids open. They just want to clench. And the treatment for that is Botox. It's typically not neurologically dangerous, but they need Botox treatment so they can open their eyes. And usually Botox treatments every 3 months. So that's benign essential blepharospasm. Again, this kind of clenching of the eyes. Okay. There's apraxia of eyelid opening. So essentially here, what happens is they close their eyes and then they can't open their eyes. And, it takes really hard for them to open the eyes. And then again, this is apraxia of eyelid opening. Sometimes we can see this in neurodegenerative conditions. Sometimes we can see it as idiopathic. Hard to treat. Sometimes we try Botox and other things like that, but it's pretty hard. It's just hard for them to open the eyes, as you can see there. Okay. Then we got hemifacial spasm. So here, what you're going to notice is spasm of just one side of the face. There. There, right there on the right-hand side. So it's not just the eye, but you're going to see some twitching. There it goes again. There's some twitching of the eye and the face. So it's not just the eye, it's the face as well, and it's unilateral. So that's hemifacial spasm. Does anyone know kind of the most common cause of hemifacial spasm? And what tends to cause this? Are we usually worried about stroke, tumor? Any thoughts? The treatment is Botox as well. But in terms of etiology, it's actually not usually tumor or stroke. It's usually caused by what we think is an abnormal blood vessel. We call it a dolotictatic vessel like the basilar artery that kind of is moving and kind of tortuous and pressing on the seventh nerve and irritating it. And so it's thought to be a junction of the artery and the nerve that kind of irritates it. That's now one of the theories behind trigeminal neuralgia as well, is it's a vascular compression of the seventh nerve. So can it be caused by tumor, stroke? Yes, but very, very rarely. So I usually image these patients, but it's almost always benign, and it's actually caused by a blood vessel, the basilar artery that's irritating the seventh nerve. So do I image these patients? Yes. Do I usually find tumors or stroke? No. Again, it's usually benign, usually an artery pressing on that seventh nerve. Treatment is Botox. And then we got facial myokymia or orbicularis myokymia. This is just this kind of twitching. And it's typically benign. You can see that here, often triggered by caffeine stress. So there's some facial abnormalities that you can see. All right, we're going to switch to chapter 13, head, ocular, and facial pain, and really going to go very, very quickly here. It's just kind of looking at different kinds of headaches that you can see that are isolated often to one side. These are kind of the classic one-sided headaches, and depending on the symptoms, you can kind of tell them apart, whether it's trigeminal neuralgia, cluster headaches, paroxysmal hemicrania, sunk syndrome, hemicrania continua. These are all headaches that are just on one side or pain just on one side. And based on the symptoms, the temporal profile, you can determine which one it is. And they all have different treatments. Like hemicrania continua responds very well to endomethacin. So that's important to be able to sort out. Usually you're going to be involving your headache neurology colleagues as ophthalmologists. And then again, one thing I want to highlight in this chapter are, we see tons of patients with migraines. What are some red flags? When do we need to image these patients? Because migraines are super common. They're in 20% of the normal population, 40% of the normal population. So when do you have to image? I think if the migraines start after the age of 50, that's usually a red flag to me. Of course, if there's any associated neurologic symptoms, for sure. Any history of cancer, for sure. Was it a thunderclap headache? Is it kind of worsening and worsening and worsening over time? These are kind of red flags that you should look for and know when you should image. And imaging should be an MRI plus or minus an MRA, because again, you're looking for dangerous etiologies like dissection, aneurysm, a subarachnoid hemorrhage, tumor, all those kinds of things. So these are the red flags you should look for. All right, functional vision loss, super briefly going to just go through this. So unfortunately, we've got patients with functional vision loss. I've heard that it accounts for maybe up to 2 to 3% of visits to ophthalmology clinics. And oftentimes they take a lot of time to work up. We've got little gadgets that we can do to kind of determine good vision. One is the OKN drum, and if they've got a good motility response to the OKN, as you can see here, that indicates the vision's at least 2200. You need to have 2200 vision to be able to see those stripes moving. Another one is we sometimes look at stereopsis. You think of stereopsis as looking at 3D vision. What's interesting is to be able to pick up very, very subtle stereopsis, 3D vision, you actually need good vision in both eyes. Not only your eyes to be aligned, but good vision in both eyes. So if they can actually see all 9 out of 9 circles, that means they typically have 20/20 vision. So that's a nice way to demonstrate good vision. We've got a lot of other tests as well. And then last chapter that we're going to touch upon is systemic disease. And again, we could spend hours just on systemic disease that involve the eyes, like multiple sclerosis and others. We're just going to briefly talk about Janssen-Watteritis, because you probably heard about optic neuritis in chapter 4, chapter 5, when you talked about vision loss and optic neuropathy. So let's just talk about Janssen-Watteritis. This is just a classic patient who came in with acute vision loss in one eye. She had headaches, she had pain when she chewed. She was 2400 in both eyes with this pallid disc edema. So really the only thing this could be is Janssen-Watteritis, because that nerve is so pale. If you compare that to what's much more common, non-arteritic anterior ischemic optic neuropathy is 10-fold more common than arteritic anterior ischemic optic neuropathy from Janssen-Watteritis. But you can see that disc appearance is so different. With NAION, you get this hyperemic nerve with sometimes some peripapillary hemorrhages. With Janssen-Watteritis, you get this pallid disc edema. Because instead of ischemia, it's an infarction of the nerve. The vision's often very, very severe. So if you see pallid disc edema, has to be Janssen-arteritis. It's not going to be non-arteritic anterior ischemic optic neuropathy. Of course, this patient's inflammatory markers were sky high, treated with steroids, the biopsy confirmed GCA, and the headaches resolved with steroids, but unfortunately, she remained legally blind at 2400 both eyes. And what's frustrating about this is the steroids doesn't reverse the damage that's there, but what it can do is prevent vision loss in the other eye. And because she actually presented with vision loss in the right eye first, and then had vision loss in the left eye 2 weeks later, if the correct diagnosis was made, that left eye could have been saved. And I know, at least in the States, Janssen-arteritis is one of the most common diseases that ophthalmologists actually sued over, because if you miss this, it's not really defensible. If someone comes in with pallid disc edema and you don't think about Janssen-arteritis, and then say it's NAION, and then 2 weeks later they lose vision in the other eye, not really defensible, because it really has to be on a differential diagnosis. So in terms of Janssen-arteritis, it's a granulomatous inflammation of large and medium-sized vessels. It's the most common primary vasculitis in adults in the Western world. It's more prevalent in northern latitude, especially Scandinavian descent. So I practice up in Rochester, Minnesota at the Mayo Clinic. I see a lot of Janssen-arteritis. But if I were to practice, down south, in Texas, I think it'd be much, much less common. The biggest risk factor is age. The median age is 75. It's almost non-existent in patients younger than 50. And in terms of what to look for, arteritic anterior ischemic optic neuropathy is the most common way that Janssen-arteritis causes vision loss. 2/3 of the time they'll have pallid disc edema, and typically the vision is 2200 worse. Oftentimes they'll have systemic symptoms of GCA, so that's headaches, scalp tenderness, jaw claudication. But it's important to note that up to 20% can be occult, which means they come in with vision loss without any systemic symptoms. So they might not necessarily have to have headaches or scalp tenderness or jaw claudication. So for me, I get an ESR CRP on any ischemic optic neuropathy in a patient over the age of 60, because I'm looking, could this be Janssen-arteritis? In terms of ophthalmic manifestations in GCA, again, the most common is arteritic anterior ischemic optic neuropathy, but it can also cause ciliary-retinal artery occlusions. It can cause central retinal artery occlusions, ocular ischemic syndrome, pretty much any kind of ischemic disease. Oftentimes, patients will have transient vision loss before the vision loss occurs more permanently, and it causes double vision of any pattern. It can cause ischemia to the muscles, to the brainstem, to the cranial nerves. So any kind of double vision in a patient over the age of 60, I also have GCA on the differential diagnosis. And the treatment really is immediate steroids. There's no, as we mentioned, there's no recovery in the affected eyes. The steroids are to prevent vision loss in the other eye. And the temporary biopsy done within 2 weeks of starting the steroids. You're starting steroids first, and these are just some classic granulomatous inflammation, occluding the entire lumen of the vessel. And then I usually refer them to rheumatology, because they often need to be on prednisone for over 2 years, over a year, sometimes longer. And it's important to have rheumatology on board to kind of help manage the steroids and the side effects. And exciting, we actually now have tocilizumab. It's an IL-6 inhibitor, proven to be effective as a steroid-sparing agent in Janssen-arteritis, and now is the first FDA-approved steroid-sparing agent for GCA. And so again, our rheumatology colleagues help us with this.
Oh, thank you, Dr. Chen, for the most riveting session. I really enjoyed it. Personally, I really enjoyed it, and I learned a lot from it. I think neuro-ophthalmology is definitely something that you need multiple repetitions for. There will be a recording of this session, just like all of the sessions, on the HCP virtual classroom website. And I open it up to questions from everyone for Dr. Chen.
In terms of pupils, did that make sense in terms of anisocoria? So I just think it's interesting that anisocoria really strikes fear into people. But really, the things that you're worried about with anisocoria, it's really 2 things that are neurologically dangerous. It's Horner syndrome and third nerve palsy. The rest actually aren't dangerous. But again, with the Horner syndrome, you're going to have a little bit of ptosis. With the third nerve palsy, you're going to have a dilated pupil, but you're also usually going to have ptosis or motility deficits. So again, isolated anisocoria should not strike fear in your heart. And yet it does, again, because we're worried about aneurysm, third nerve palsy, we're worried about cry dissection, Horner syndrome, but they're never in isolation. So when that ED doctor picks up the phone and says, I have to see ophthalmology stat, they've got a blown pupil. If you go there and there's no ptosis and there's no motility deficits, it's probably not going to be anything dangerous. It's probably going to be pharmacologic or an AD's pupil. So that's really important, but you really have to look at the lids and the motility really well when you have anisocoria. A big question is, how do you grade for an RAPD? What we do here is we're shining light in the eye. If we just shine it slowly, both pupils constrict. And then so at this point, if you're in med school, what I've often seen is they'll put PERLA, pupils equal round in reaction to light and accommodation, even though they didn't even check accommodation. But if you do the swing flashlight test, now you can see there's a clear RPD in the right, which you couldn't see before. So again, I do 2 seconds per eye and just swing it back and forth. 2 seconds per eye, swing it back and forth. And then to quantify it, what we do is we actually put a filter in front of the good eye to kind of block the light. And then by increasing the filter amount, you're going to see that we can balance out the amount of response. And so now when you shine in both eyes, just both barely constrict. And this ended up being about a 0.9 log APD. So that's how I tend to quantify it. Otherwise, you could have quantified this as, 1+, 2+ APD, that if you want to just kind of get a gestalt. But if you want to actually quantify it, you can put these filters in front. Let me show this one here. Can you see this video as well?
Yes.
So this is that pupil with the trauma here. So then you can see it doesn't respond to light. So then, you could argue, well, if it doesn't respond to light, there's no way to check for an RAPD. But in this patient, you actually can. What you're going to do is you're actually going to look at this pupil as you shine the light between the two eyes. If you shine the light over here, you can actually see that pupil, the left constricts. We call it checking for an RAPD by reverse. So it constricts to direct light. And if you shine on this eye constricts. So that means this right eye is seeing light. This patient actually was interesting, came in saying she was no light perception. But the fact that the left eye constricts when you shine it in the right eye means that the eye can see light. But now that I'm doing the swing flashlight test, if you can just look at this eye, you can see it dilates a little bit when I shine it to the right. So there is a small APD there. We just know she's not no light perception. And again, we can quantify it by using these filters. This ends up being about a 0.6 log APD, which neutralizes the APD. So again, the pupils are really nice, especially if they say they're completely blind. You're going to look for that APD. And if they're completely blind, there should be a complete APD. If there's no APD, they're functional. But yeah, that's a pretty hard one, to checking APD by reverse. Another question, why is APD not common in unilateral glaucoma? It actually is very common in unilateral glaucoma. It's just unilateral glaucoma is not that common. Glaucoma tends to be bilateral symmetric. So that's why we don't tend to see glaucoma causing APDs. But if it's asymmetric or unilateral, you will definitely have an APD because, again, it's all about relative visual field loss. It's just less common because glaucoma tends to be pretty symmetric. So in terms of nystagmus in children, again, one of the main reasons you can tell it's nystagmus in children is that their eyes are bouncing all over the place, but they have no oscillopsia. That means it's been there a really, really long time. Because if any of you got nystagmus, your eyes start bouncing, you're going to notice things are bouncing. So that's one way. And then there's congenital sensory nystagmus versus motor nystagmus. So essentially, if in a child, you can have nystagmus because your vision is so poor because you've got some kind of retinopathy that you're born with. So you never had good vision to be able to maintain fixation. And that's sensory nystagmus. Or your optic nerve is damaged since birth. Again, that's sensory nystagmus. You've never had clear vision to be able to lock in your eyes. But then there's motor nystagmus, where your optic nerve, your retina, they're healthy, but your eyes are just bouncing because it's a motor nystagmus. The way you can kind of tell that apart is motor nystagmus tends to be a visual acuity of about 20/40, not all that bad. Sensory nystagmus tends to be worse, like 2200, 2400, hence have worse vision. Plus, you obviously find something wrong with the optic nerve retina to kind of guide you that way. It's like there's a question on pharmacologic testing for anisocoria. Again, I think the main ones would be, if you're thinking Horner syndrome, you're going to want to use apriclonidine. You're going to put it in both eyes, and a positive test is the anisocoria reverses. And then the other test you can do is cocaine, and there the anisocoria actually gets larger. Those are the positive results for Horner syndrome. The other drop test that we do is if you've got an 80s pupil, you can use dilute pilocarpine, put it in both eyes, and if it's an 80s pupil, you get super sensitivity. So just a whiff of the pilocarpine will cause constriction, so that dilated pupil will constrict. So those are the main eye drops we use for anisocoria. And then the last question I saw here, can a dense cataract cause an RIPD in the contralateral eye? So yeah, a cataract can't cause an APD, but sometimes you can get this tiny little RPD in the other eye. I think what happens is the light scatters and actually you get more light in that eye with the cataract, but it's pretty small. We're talking like 0.3 log. So for the most part, you're not going to notice too much of one. So again, a cataract really just doesn't cause much of an RPD other than a little bit in that contralateral eye. In terms of functional vision loss, can a person fake visual field loss? If so, how do you check? So yes, they certainly can. There was actually a study done, I think in the 80s, where they took medical students and said, okay, I want you to fake visual field defects. They can fake inferior altitudinos, they can fake homonymous, they can fake all these visual field patterns, but they couldn't fake cecal central scotomas. So if you see a cecal central scotoma, that's typically pathologic. Most patients don't tend to fake central scotomas either, although you could fake that one. But if I see a central scotoma, I'm usually thinking that's truly real. Usually the fake visual fields are either generalized constriction or missing vision down below or missing on the sides. And then how do we check for that? If it's asymmetric, you're going to check for an APD. If they have visual field loss in one eye and there's no APD, that's fake. We do tangent screens where we check at 1 meter and then we check again at 2 meters. So if it's real visual field loss, it should expand at 2 meters. Just physiologically, our tunnel vision, peripheral vision kind of expands outward. And patients with functional field loss tend to have tubular visual field. They don't quite understand the pathophysiology that it should expand. So that's another thing we do. Another question is square wave jerk always pathologic? And no, square wave jerk is not always pathologic. In fact, it's very common in normal individuals. That's important to note, especially elderly patients. So square wave jerks are often normal. You can see them in some neurodegenerative conditions like Parkinson's disease, but they're very, very common in normal individuals. Again, there's 84 people right here right now. I'm sure at least 10 of you have some square wave jerks. It's very, very common. Unlike macrosaccadic oscillations, I was showing that video where the eyes were kind of bigger movements, that's pathologic. That localizes the cerebellum. But square wave jerks, very common in normal individuals.
Thank you, Dr. Chen, for being with us today.
It's my pleasure, really. Thank you so much for the invitation, and it was really nice to see you all today. This is a wonderful setup.